So over the next 15 minutes or so, I'm just going to provide a bit of an overview of the changes that have taken place over the last decade with regards to multi-parametric MRI. And the previous speakers have already referred to this, but the old pathway was really a digital rectal examination with the inclusion of PSA testing, which has its deficiencies, followed by systematic trust biopsy, which was transrectal historically. And then MRI at that stage was used only for local staging, i.e. to demonstrate whether or not it's actually extended beyond the capsule. And things have changed a great deal since then. And we have understood that there was a great deal of error with the previous diagnostic pathway. As the previous speakers have alluded to, the detection of clinically insignificant disease, catching the edge of the tumor, and therefore inappropriately underestimating the grade of the disease. Of course, random trust biopsy was really quite miserable at picking up anterior disease, which could be missed. And in addition to those failures, there was the risk of sepsis from over biopsy, and a risk of UTI and life-threatening sepsis of reaching up to 4% in some studies. So what's changed over the last decade? So we've moved from PSA testing to more novel techniques. Brian referred to PSA density, and there is work currently being done on more novel biomarkers such as the PCA3 and the kallikrein markers. The biopsy techniques have advanced. So moving from a random trust biopsy, we've moved to more advanced techniques, which are primarily transperineal these days. But there have also been advancements in fusion techniques, so MRI ultrasound fusion techniques and in-bore MRI biopsy as well. So what's happened to MRI? So we've moved from a very limited no-frills MRI to a very advanced MRI, and that's because of advances in technology, the fact that we can now reach very high B values, and we widely use standardized scoring systems all across the globe now, which is the PI-RADS scoring system, which I'll refer to. And the value of pre-biopsy MRI is undeniable. We can achieve a clean MRI without any hemorrhage artifact. It's of course more reliable in detecting anterior disease. For the urologist, it provides a biopsy target, reduces the pickup of very insignificant low-grade disease. Patient choice. Patients will prefer to know what their state of play is before they agree to a biopsy. For patients that then undergo active surveillance, it's very useful to have a baseline MRI free from any hemorrhage artifacts. For centers that are performing very intricate nerve sparing techniques and fascial sparing, in my opinion, a very clean MRI provides more reliable staging and allows us to more reliably assess whether the neurovascular bundle has been involved. And of course, in some patients, this will avoid any unnecessary biopsy. So let's break down what is multi-parametric prostate MRI. And in simple terms, it means multiple parameter MRI. Now, the basic sequences are, of course, the T1 and the T2 sequences. So let's complement that with one other. So that then becomes a biparametric MRI. So we've included diffusion weighted sequences. Now let's include one other. So either DCE or spectroscopy. Now this is now a multi-parametric study. And in simple terms, the basic sequences are anatomical. So they are there to assess the morphology of the gland volume, and the zonal anatomy. And then the other sequences are functional, and they look at the cellular composition of the tissue. So diffusion is looking at cellularity, DCE is looking at vascularity, and spectroscopy looks at the composition of choline within the cellular structure, although that has now widely been dropped. So let's crack diffusion restriction. So we know tumors are hypercellular, closely packed cells, and diffusion really relies on the free random Brownian movement of water molecules. So you can see here that a water molecule can freely pass through this medium. When there is normal cellular tissue, there is still free diffusion as water molecules can pass into the extracellular space. But when there is tumor, you have very tightly packed tissue, And that's when you see restricted diffusion, because the water molecules cannot escape through this very tight, dense structure. So how does that translate to what we see on MRI? So here is normal tissue and tumor tissue as we're increasing the B values. So from B value 150 to B value of 2000. So you can see that at B150, it is bright. And as we increase the B value, what happens to normal prostate is it becomes darker. So what happens to tumor? As we increase the B value, the tumor impedes the restriction and that remains bright. And this next slide beautifully shows that. So as we're increasing the B value from 100 to 2500, the normal prostate is actually becoming more faint and darker of low signal, and it's the tumor that pops out. And that is the beauty of the diffusion sequences. If you skip straight to the high B value, you will see the tumor pop out because the normal prostatic tissue is suppressed. And maybe even simpler, if you remember that B value, B for bright. So if there is an area of brightness on the B value, that's likely to be tumor, and then correlate that with the ADC map. So D for dark. If that same area is then dark on the ADC, then that is true diffusion restriction. And this is a tumor within the left posterolateral peripheral zone. So let's move on to contrast. We know that tumors have abnormal vascular structure due to neoangiogenesis. And because they form vessels very quickly, the endothelium is usually very poorly formed. And for that reason, it's leaky. Now, when we give contrast, we give gadolinium, which has a low molecular weight. And it readily leaks out of the tumor through these leaky vessels and then rapidly washes back in. And from that, we can infer the DCE curves. So the red line is what tumors would normally manifest as. So there will be an early enhancement pattern, and then the enhancement pattern will very quickly drop off, and that's the washout. So there are several studies that have shown that you can differentiate between tumors in that a benign tissue will normally represent a type 1 curve, which is the dashed blue line, and tumors will represent the red curve. And in some studies have quoted 90% specificity for cancer. Although having said that, other studies have suggested that there's inability of curve typing to accurately differentiate malignancy, which I would wholly agree with. And that's because prostatitis and BPH can also demonstrate the same enhancement pattern. So let's move on to PI-RADS. Now, PI-RADS is now widely adopted globally. And this started with a joint venture by the ESUR, ACR, and a non-profit foundation known as Admatec. And it's moved on to version 2.1 now. And I would say that the most important thing to remember now about PI-RADS is that with greater understanding and research, we've realized that actually there are different sequences which should be assessed for different areas of the prostate. So the peripheral zone, the dominant sequence is diffusion, and the transition zone, the dominant sequence is the T2, which I'll move on to explain. There's been a general downgrade in the value of DCE, and this is now usually used to upgrade an indeterminate lesion from a 3 to a 4. And the differences between a PI-RADS 4 to a PI-RADS 5 is based on size, so 1.5 centimeter tumor, or if there's any evidence of extracapsular disease. And as Helen nicely outlined, similar to the Gleason grade, and there is also a traffic light system where 1 is highly unlikely to be tumor and 5, which is in red, highly likely to be clinically significant cancer. So I'd just like to take you through a few MRI images. So this is a T2 sequence, and you can see on the left, this beautiful high signal peripheral zone. So this is normal. This is what a peripheral zone should look like. And on the extreme, you can see that there is a mass within the left peripheral zone, which is bulging the capsule. So this would typically be a 5 score. So let's look at the transition zone. So this on the left is a normal appearance of a transition zone. So it's described as an organized chaos appearance because you have multiple nodules which all have a low T2 signal rim, and that's normal. That's a benign appearance. Now, moving on, you can see here that there is a very ill-defined area of low T2 signal, and what we describe as the erased charcoal sign. So there's a lenticular mass in the anterior part of the gland, and this is almost certainly going to be tumor. Now, an additional tip from my own practice is that if you draw a line and divide the prostate into an anterior half and a posterior half, it's very, very rare to actually see tumor in the posterior part of the transition zone. And I would say that in 90% of the cases, the tumor will usually start from the anterior part and then progress posteriorly. So beware, if you are going to focus your eyes, focus on the peripheral zones, of course, because most tumors arise in the peripheral zone, 90%, and then the remainder are predominantly in the transition zone. If you focus your eyes on the anterior part of the gland, that's where you'll see a tumor, and focus on the T2 sequences. So the take-home message for transition zone. Now, diffusion we've already touched on, but as you can see on the right-hand side, a lesion that is bright on the B value and dark on the ADC is going to be a 5 score. Now, I don't want to overcomplicate things, but this diagram just shows the move to different dominant sequences for different zones. So for the peripheral zone, as I mentioned, diffusion. Now, if you have an indeterminate score, then you can use contrast to upgrade it. So if that area is also enhancing on the contrast, you can upgrade that lesion from a 3 to a 4. And that is now the new role for contrast. For the transition zone, I mentioned that the most important sequence is T2. And in this case, if you have an indeterminate lesion, to upgrade that to a 4 is the diffusion. So it's the flip side from the peripheral zone. And this is widely available on the internet if you just search PI-RADS 2.1. And then we finally reach this traffic light system. And I would say that in our center, the greens, unless there was a high PSA density, we would avoid biopsy. The 3s, we would take into account any previous risk, ethnicity, PSA doubling time, kinetics, whether they were biopsy naive, and the PSA density to determine whether or not they would be biopsied. And the 4 and 5s, we would almost certainly biopsy. So let's put that into context. So this is an example of a prostate MRI, and there is clearly a lesion within the left peripheral zone. So it's low signal on the T2. But as I mentioned before, the dominant sequences for the peripheral zone is the diffusion. So let's focus on the diffusion. So it's dark on the ADC, bright on the B value. So that's almost certainly going to be positive for tumor. But then we have to look at the size. So the size is 14 millimeters, and it doesn't appear to be going out of the capsule. So that's a PI-RADS 4 because it doesn't quite reach the threshold of 15 millimeters. Another lesion here, so a larger lesion in the left peripheral zone. You can see it's bulging the capsule. So that's probably an early sign of at least microscopic T3A disease. It's dark on the ADC, bright on the B value, and irrespective of its size, because I feel that this is probably going out of the capsule, this will be a PI-RADS 5. Now this now gets a bit more tricky, and this is the typical appearance of a young man's prostate. So someone in the range of 40 to 50 years of age. Now they have very glandular tissue. So generally the T2 sequence, the peripheral zone, just appears diffusely of low T2 signal. So it's very difficult to actually find a lesion within this on the T2. Now on the ADC, there is a mild drop in signal in the peripheral zones, as you can see there. On the B value, a mild generalized increase, but there isn't an obvious target lesion. And then the contrast sequences don't really help there because it's just diffuse enhancement. So this would be a 3. And we would need to have a careful consideration as to whether we need to biopsy this patient or not. This is a PI-RADS 2 because even though there is low T2 signal in the peripheral zone, there is absolutely no diffusion restriction. So that is benign. But in the same patient, towards the apex, there is a lesion which is low signal, diffusion restriction, and you can see this early enhancement. And of course, because it's less than 15 millimeters, this is a PI-RADS 4. So just very quickly moving on to the diagnostic accuracy of MRI. It's a bit of a gray area, but there has been some significant progress in the last 5 years or so. And this article from BBC News 3 years ago now, a huge leap in prostate cancer testing. Prostate Cancer UK and several hospitals within the UK have embarked on the PROMISE study, which is really a landmark trial, certainly in the UK, with regards to prostate MRI. So this was a prospective paired cohort confirmatory study, multi-center throughout the UK. A total of 740 men were enrolled, and they used a 1.5T scanner with a multi-parametric format. And instead of using PI-RADS, they used a Likert scale, which is very, very similar. Now, the aim of the study was to compare multi-parametric MRI with systematic trust biopsy. And they tested against different definitions of clinically significant prostate cancer. So the primary definition was Gleason grade 4+3, or a maximum cancer core length of 6 millimeters. And this was published in The Lancet in 2016. So essentially, these men had a prostate MRI. They then had a transperineal mapping biopsy, and the individual performing the biopsy was blinded to the results of the MRI. At the same sitting, they then had a systematic trust biopsy. So what were the results? So MRI clearly outperformed trust biopsy. I think that is the one conclusion we can draw from this study. So MRI had a sensitivity of 93%, where trust biopsy alone had 48%. Of course, the reference test here was the transperineal mapping biopsy. In terms of negative predictive value, for Gleason 4+3, MRI was 89% and trust biopsy was 74%. So MRI clearly isn't the magic bullet here, because it's still missing some significant disease. The authors concluded that MRI could avoid biopsy in 27%, and that trust biopsy performs very poorly, but it's worrying that MRI missed 17 clinically significant cancers, which were all Gleason 3+4, with a core length up to 12 millimeters. But interestingly, trust missed far more. So 106 clinically significant cancers were missed, and trust biopsy missed Gleason 4+3 cancers. But MRI picked up all of those. And then a study more recently, which is a systematic review where the authors compared prostate MRI with or without MRI targeted biopsy and systematic biopsy for detecting prostate cancer. And the overall conclusion was MRI is integral to the pathway and has the most favorable diagnostic accuracy in cancer detection. And if you were to compare that to systematic biopsy alone, we would increase the number of significant cancers detected and also reduce those that are detected of low grade. And so I think it's clear that MRI is here to stay. It's not the magic bullet. It has its flaws, but it's part of the armory, and it should be used as a risk stratification tool. And my conclusion slide is that there has been a paradigm shift over the last decade. And I welcome the widespread use of pre-biopsy MRI for the reasons that I've discussed. There have been significant advances in technology. We are now able to hit those high B values, which we weren't able to several years ago, which are both highly sensitive and specific for cancer detection. Of course, we have fine-tuned and continue to fine-tune our scoring systems. So PI-RADS started several years ago with a PI-RADS version 1, and now we're up to 2.1, and with 3 due to come in the next couple of years. I think it's clear that MPMRI is more accurate than a random trust biopsy. So MRI can at least guide the target. And we can now adopt a targeted biopsy approach. With the new MRI-directed pathway, we can reduce unnecessary biopsies and, of course, reduce overtreatment and otherwise improve the quality of life for and the anxiety for patients that would be diagnosed with low-grade prostate cancer. I would just like to inform you that we are working on a learning package which will be free and available to everyone across the globe from October. This is a joint collaboration between the BSUR, who I'm a part of, Prostate Cancer UK, and the University of Oxford. And it's known as the Reiki package. And when this is up and live, you'll be able to review more than 200 prostate MRIs with histological validation. All of them will have their individual learning points with each case, and you'll be able to compare your performance to your peers. And you will also be able to download certificates for your own portfolio. But this is going to be a free online package which will be available after October. So watch this space, and thank you for your attention.